Hi, I'm Sarah Bruce and welcome to EHI TV. I'm now joined by George MacGinnis from PA Consulting, who also ran and led the telehealth project for Connecting for Health. Welcome, George.
Well, thank you.
You're obviously one of our speakers today. Tell us a bit about your session and the topics that you've covered.
So, what I was looking at was really, we've got the whole system demonstrators just coming to an end. What's next, and where's mainstreaming going to go for telehealth? And what are the lessons that we can draw, not just from the whole system demonstrators, but from implementations up and down the country? What does that really tell us about how we move to the next scale and get things mainstream?
So telehealth has had actually quite a lot of press coverage recently, especially in the light of these NHS reforms and joining up health and social care in particular. Do you think this is going to be the driver to really push telehealth through once and for all? Because really the uptake's been quite slow so far.
Well, it has been slow, and I think for some interesting reasons. I mean, some of it is cost, some of it are sort of policy and regulatory barriers. We don't yet really have a way of paying for it. You know, there's a financial logic to it, but the tariffs don't yet work there. Some of it regulatory, some of the way that medical devices are regulated act against that, and we see similar sorts of issues with integration in health software generally. But really, the main reason I think that most people have been sceptical up till now has been a lack of really good evidence. And I'd say, you know, we can point to a sea change in that situation now. So first and foremost, nearly 2 years ago now, the US Veterans Health Administration published their evidence on telehealth in the way that we would think of it. And they produced some really, for me, quite staggering results. They were observations on operations in the vets involving 17,000 people, and they were delivering all the sorts of cost, quality of life, productivity benefits that people have been predicting telehealth could deliver, and also beginning to indicate what the sort of cost of a service was when delivered at scale. So for them it was about $1,600 per patient per year. So if that's someone who's going to be saved at least one emergency admission, you could begin to see there's a real business case for this. So that came over from the States. The vets are very close to a National Health Service style implementation, but have differences. I think with the whole system demonstrators, where we're now at the end of the intervention phase, they're literally data crunching now and moving to mainstream within their local areas. When those results come out, they're hugely important in moving the UK to the next step.
So you obviously can't say too much about the actual results and the outcomes of the whole system demonstrator, but what actual stage is that at now? I mean, is it being reviewed? Is the project actually complete, the pilots, are they complete?
So the intervention is complete. So the demonstrators involved actually quite a lengthy process of one, actually getting some funding and pulling the concept together, sorting out bids, identifying who were going to be the sites, then allowing the sites to do their business design, then kick off patient recruitment, and that in itself took quite a long time. What the demonstrators were actually trying to measure was what's the impact of a telehealth service on a patient for a year. So it required all the patients to be recruited. That was a trickled process. In September we got to the point where the last patient had been through the full year's intervention, and now they're moving into mainstreaming. And actually some of that mainstreaming involves giving the people who didn't get an intervention, the control group, offering them telehealth services and saying you can now benefit from what the other people were doing. So we're at that stage. The academics expect to publish their reports round about spring next year. Certainly the King's Fund has lined up a big conference in early March where clearly this is going to be top of the agenda. Where do we take it? So the demonstrators, I think, are in a really good situation. But if you look underneath the headlines, you'll find, for instance, that Cornwall announced before the end of their demonstrator program that they were going to mainstream their service. They were going to broaden the scope and offer it to other people. And I think we'll see that elsewhere as well. You know, there's a real desire in terms of pulling together large-scale implementations. And in the last year, I would say that there are certainly 3 or more SHAs who've moved to put large-scale implementations on the map. Big plans in Yorkshire and Humber SHA and North Yorks and Yorkshire PCT, already planning something big. West Midlands are doing a lot, and there are others as well, and I'm sure there are others waiting in the wings, just not wanting to reveal their cards at present.
Do you still think there's a bit of concern, especially in these financial times, that there's not enough return on investment, and it's difficult to kind of quantify what's more important, well, not what's more important, but the patient care, and improving patient care at home in particular, and return on investment for hospitals in getting them to invest in this technology?
Well, I see it slightly differently. I don't think we yet have the tariffs to drive adoption. So I think there is a financial logic. I think we have a very good understanding now of which sort of patients offer relatively short-term return on investment, and I mentioned a little bit in my talk. So most of the focus has so far been on people with essentially limiting long-term conditions. So their condition means that their activities of daily living, the ability to go shopping, to walk upstairs or things like that, are in some way impeded. So they're quite highly motivated to actually stick to a regime that seems to give them some quality of life, and they'll put up with the limitations of, let's call it the technology or whatever, in order to achieve that. So we understand some things, and certainly I think from the demonstrators and elsewhere, heart failure and COPD look like really good target conditions. There are aspects of diabetes which work, but not all aspects of diabetes are suitable for the sort of stuff that we're doing now. And again, Cornwall, expanding into post-TIA, pre-stroke patients, falls with postural stability and postural hypotension. So I think lots of things that can be done. And part of the art is to say, what can we do now? How big do we have to be to do it efficiently? And then when we set off and buy what we do now, do we have an eye for the future? Do we know where we want to expand to? And are we actually getting the right infrastructure in place to be able to make those longer term moves in 5 to 10 years? Because it's my belief that the decisions made on systems today will define what people are using in 5 to 10 years' time. And if you've got the wrong platform, if your supplier isn't up for broadening the scope and including all sorts of interoperability and integration with other devices, then you may find yourself taking one step and one step only.
Okay, thank you very much, George.
Thank you.